Good afternoon, everyone, and welcome to today's Care Connection webinar on preventive care for us and the people for whom we care. My name is Susan Shipman, and I'm a social worker here at the Alzheimer Foundation of America. I am very pleased to welcome you to this important webinar today. Before I introduce Dr. Leipzig, I'd like to go over a few things. All the lines are muted, but we encourage questions, so please feel free to put questions on the right-hand side of your screen in the question box. We will have a brief Q&A at the end of the webinar. Any questions you have for AFA, for the Alzheimer Foundation, please feel free to call our helpline, which I will include in the wrap-up email, along with your certificate of attendance and any handouts in the next day or so. Additionally, Dr. Leipzig has, which I will include in the with the email. The webinar itself will be available on the AFA website later, and I will include that information as well in the email. All that said, let's get started. We are very fortunate to have Dr. Rosanne Leipzig with us today as our guest speaker. Rosanne M. Leipzig, MD, PhD, is the Gerald and May Ellen Ritter Professor, tenured, and the Vice Chairman Emerita of the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai in New York. Dr. Leipzig is an internationally recognized leader in geriatrics and has received numerous awards for her work, including the American College of Physicians Richard and Hinda Rosenthal Foundation Award, a Joy McCann Scholar Award recognizing her expertise in mentoring and medical education, the 2008 Dennis W. Yonigan Memorial Award from the American Geriatric Society, a Brookdale National Fellowship in Geriatric Medicine, and in 2014 received the Paula Edelbrick Community Service Award from Services and Advocacy for GLBT Elders, SAGE. In 2016, she received the Jacobi Medallion, one of the highest honors from the Mount Sinai Health System. She is also the editor-in-chief of Focus on Healthy Aging, a monthly newsletter for consumers, and past chair of the Geriatrics Working Group of the United States Preventive Services Task Force and the American Board of Internal Medicine Super Specialty Board on Geriatric Medicine. She has published over 100 articles and was the deputy editor for the 4th edition of Cassell's Geriatric Medicine. Her forthcoming book, provisionally entitled Honest Aging, an Insider's Guide to Medicine, to the Second Half of Life, will be published by Johns Hopkins University Press in early 2023. And I will include the name of the book in the post email as well. And now I'll turn the webinar over to Rosanne Leipzig. Welcome, Dr. Leipzig.
Thank you so much, and it's really a pleasure to be here. If we can have the next slide, please. So when you start to talk about screening and prevention, there are differences that we're going to be talking about for yourself as caregivers or for your loved ones who may be living with dementia. And these are just some of the things that we hear about over and over again. And of course, we can add in the new COVID bivalent booster as well. But, you know, should I get a mammogram? Should I have a pneumonia shot? Should I get my PSA checked if I'm a man? Should I be taking aspirin? Do I need a colonoscopy? Should I be screened for diabetes? Do I still need a pap smear? How about a tetanus shot? So what we're going to do in the next hour or 40 minutes or so is go through these things and try and develop a simple way for you to decide what you should have done and what your loved one should. So if I can have the next slide, please. We're going to start, okay. What we're going to discuss, if we can have the next click, we're going to discuss how to decide whether you or your loved one who's living with dementia should undergo these tests and procedures. We're going to talk about what the difference is between prevention and screening. Click. what I call a yearly tune-up, click. And under prevention, we're going to be speaking about, click, click, infections and cardiovascular disease. And for screening, what is different about screening when you're older? And the two things we will be discussing there are, click, click, cancer screening and screening for other diseases. Next slide, please. So there's certain things we know about caregivers of those who are living with dementia. Click. The first thing is that almost 3/4 report being somewhat concerned or very concerned about maintaining their own health. It's not surprising, is it? When we're talking about a 36-hour day with many people. Next. 27% in a 2017 survey said they delayed or didn't do the things they should have done to maintain their own health. And click. They report lower health-related quality of life than non-caregivers and are more likely to report that their health is fair or poor. And that's a really good question to ask. We in medicine tend to ask people, how would you self-rate your health? And people who say it's excellent or good, it usually is. And people who say it's fair or poor, that's usually the case as well. How about living with dementia? Click. Well, one of the things about living with dementia is it increases the likelihood that you'll have a bad outcome if you have an invasive procedure like surgery. And what we're talking about here are things like delirium, becoming more confused than you were before, ending up having to use restraints, being deconditioned because you haven't been moving because of the delirium and the restraints, and then you fall and lose some of your activities of daily living, the ability to ambulate, the ability to get yourself into the bathroom, for example. Next. Another thing that we know, and this is a hard one, is that dementia decreases life expectancy. Next. So the average time to death for all types of dementia is about 6 years. Now there's a lot of variability there. And particularly with Alzheimer's, this can go to 12, 15 years. Next. People who have dementia that is not the Alzheimer type of dementia tend to have a shorter life expectancy. Next slide. So given those two things to think about your particular situation and how you make those decisions, I'm going to spend a couple of minutes just talking about what prevention is and what screening is and how they differ. So the next click. So prevention is changing behaviors or taking a vaccine or a medication to prevent the development of condition so that you will never get the condition. That's what we're trying to do with COVID vaccine, although it doesn't totally work in that way, and with flu vaccines. Screening, you already have the disease or condition, but you don't have symptoms from it, so you don't know that you have it. And the question is, if you get it early, will it change the course for you? Next. So with early detection, we try and intervene so that the course of the disease will change. Okay. Next slide, please. So you may ask the question, why aren't all recommendations the same? And you probably should. You've seen this over and over again. Click and click. So sometimes you hear going out in the sun is good for you. You need sun, okay? It's good for vitamin D. On the other hand, you'll hear the dermatologist say sun is bad for you, okay? It can cause skin cancer. We hear some people say for preventing cardiovascular disease, alcohol is good for you. I think we all know how alcohol can be bad for you. So why aren't they the same? You need to look at the fine print. How much of whatever this is do you need? And under what circumstances is it good? And what circumstances is it not? Next. So it's one of the biggest differences in things to tell you whether the recommendations are going to be the same or different is to look at the group that wrote them, okay? And next, specialty societies like cancer societies often are written by doctors who primarily see people who are already diagnosed with the disease. That's what they see day in and day out. So they mainly see the benefits of treating it, and they often make recommendations that are biased toward screening. Whereas primary care providers, click, are more likely to refer many people for screening and have very few of them diagnosed with the disease. But they also see patients who are harmed without any benefit from the testing, so they tend to be more, or the treatment, so they tend to be more conservative in their recommendations. Next slide, please. And there are new studies published that change the recommendation, which is, and it depends on where you are in the course of that, which recommendation you're seeing to know which one, what you should be doing. It takes years for things to catch up, I have to say. Next slide. So the USPSTF, which I was lucky enough to serve on for 5 years, click please. It's an independent body that consists of primary care physicians, nurses, and other experts like statisticians, public health professionals, and epidemiologists. Click. And tends to be the most conservative. The only recommendations they make is when there is really high quality evidence, unlikely to change, that shows screening or prevention results in a greater benefit than risk to the well-being and survival of most people, not just an improvement in their laboratory tests. Okay, next. So that's kind of an overview of prevention and screening and how these recommendations are made. What do you need to know? Well, the first thing you need to know is how long it takes for whatever you're going to do to benefit you or your loved one. So let me give you some examples. It takes 2 to 4 weeks for immunizations, if you'll click, just keep on clicking, for immunizations to work. So you get that COVID booster, and it takes 2 to 4 weeks for you to get the maximum effect of it. All right, that's pretty quick. If you stop smoking, within weeks, you decrease your risk of having a heart attack, you improve your lung function, and you decrease that feeling of shortness of breath. After a year, your risk of a heart attack will be cut in half. One thing that many of us are concerned about, particularly those who are living with dementia, is having a hip fracture and from osteoporosis. And there are medications that can decrease fractures. They take from about 1.5 to 2 years to work. So I just had a conversation yesterday with someone. She was 97. And I said to her, you know, this can take 1.5 to 2 years, but you've already fractured one hip, so you know what we're talking about. Do you think you should try it? And she said, absolutely. She didn't want to go through that again. For cancer screening, it tends to take much longer to benefit because we catch it when it's very, very small and have to wait until it would cause suffering or death. So when you look at colon cancer, it takes about 10 years before we're able to see fewer deaths from the screening. And when you're looking at prostate cancer, and it depends on the age and the type, if it does help, it takes at least 10 to 15 years, which is why we oftentimes stop screening for prostate cancer in men who are 70 and older. Next slide, please. So what's important, I keep forgetting what's at the end of the slides. What's important is you keep this in mind because you want to live long enough to get the benefit of whatever it is you're going to put yourself through. Okay. So let's talk about prevention. Remember, this is so you don't ever get the disease. That's what we're hoping for. Okay. Or if you get it, you get a much easier course. So for me, there is Prevention 101 for older adults. And if you can just click through these and then I'll go through them. Okay, we'll go back to the Slide before, good. So the first, I had a friend, he was 300 pounds. He was actually a nutritionist. He smoked like a chimney. And his major question to me over and over again was, should I get a PSA to prevent prostate cancer? And I said, if you want to improve your health, there's a whole lot more you could do that is much more likely to improve your health. And the first is to stop your smoking, okay? The second, and most older adults have actually done that. Only about 10, 12% of older adults still smoke. Limit your alcohol consumption to no more than 1 drink a day. And if you're living with dementia, that's really important because everybody gets more bang for their buck. With alcohol, you become a cheaper drunk. It takes less alcohol to give you that high. And if you already have dementia, your brain is very sensitive and you will have even more of a response than you probably want from drinking the same amount as you used to drink. Exercise regularly. It is the only thing that we've seen that helps prevent the development of dementia. Monitor your weight and eat nutritiously. You don't have to worry about being overweight as much as you get older, unless it's really causing a problem with your health. If you've got osteoarthritis and your knees are bothering you, lose some weight. It will help. But if you're a size 16 and you want to be a size 14 and it's not really making a big difference in your health, that's up to you. There's more of a problem with undernutrition than with overweight in older adults. Use seat belts in all vehicles, including taxi cabs. You can tell I'm a New Yorker. Socialize regularly. We learned the importance of this during COVID. Do everything you can to prevent those falls and fractures. And people who are living with dementia, when they fall, are more likely to fracture. So they come down harder. They don't have the reflexes to try and stop the fall. And avoid extreme heat or cold. Your internal thermostat doesn't work as well as you get older. And if you must go out, stay hydrated and make sure you dress appropriately. Now, next to each one of these, you may see a yellow star. And those to me are the ones that really can affect people who are living with dementia the most. Okay? Doesn't mean the other ones are not important, but it does mean that it can make a big difference to their day-to-day existence. Next slide, please. And if you'll show us all of these again. So I consider this to be the yearly tune-up. Everyone should see an eye care specialist every 1 to 2 years. Why? Because glaucoma, macular degeneration, and cataracts can really impair your vision. And glaucoma and macular degeneration creep up on you. You don't even know it's happening until you've really lost significant vision. So it's something you want to have seen early and something done about. See the dentist once or twice a year to prevent tooth loss and gum disease, because eating and enjoying food is really an important part of life, and you don't want to lose that. When you see your primary care provider, have your blood pressure and weight checked. Review medications, including supplements, and ask if there are any medications you can stop taking. It's very interesting. People get started on medications and we see that they stay on them for years and years and years, even when there's no indication for them anymore. And when you ask doctors why they don't stop them, they think that the patients would be upset. So if you ask for it, then you're more likely to have that happen, okay? Review and update your advanced directives. Who will speak for you if you can't speak for yourself? Get your flu shot in the fall and check if you're due for any other immunizations. We'll be talking about that in a moment. Review your history of smoking, drinking alcohol, using recreational drugs, exercising, how you spend your time, and ways to change your lifestyle if that's needed. Now, again, I have these little stars here for people who are living with dementia. And the reason I have that next to blood pressure and weight is twofold. The first is that there's data that blood pressure control can help decrease the progression of dementia, and that you can have blood pressures going down to as low as 120 and actually improve outcomes even in frail older people. And wait, because oftentimes people who are living with dementia lose weight. And it's part of the disease that can be very hard to get people to maintain their weight. And the number itself isn't what matters. It's getting the calories in, because food is fuel. And you really want to be able to have the energy to do things. The medications, because there are lots of medications that can make memory and cognitive behavior worse. So it's really important to go through them. And some of them are supplements. And the rest of these, I think, are pretty self-evident, particularly for somebody who's living with dementia, to be able to say and have written down in a document who will speak for you if you can't speak for yourself. Okay? Next slide, please. And again, just go through them. So these are all things that the USPSTF doesn't suggest that you get screened for. On the other hand, and the reason is that they don't have outcomes, the studies just haven't been done to show outcomes that really matter to patients. On the other hand, there are things that can be done, and boy, these can really interfere with your quality of life, okay? So, and a lot of times healthcare providers don't ask these questions. So you may have to ask them. If you're leaking urine, if you're having difficulty walking, or you've fallen, or even if you're afraid of falling, physical therapy can be incredibly helpful. If you're worried about your memory or your thinking, if you're feeling sad or unmotivated a lot of the time. So depression itself, major depression, is less common in older people than in younger people, but symptomatology of depression is more common, and things can be done for that. And oftentimes older people won't say they're depressed or sad, they'll get irritable. And that will be the way we know. Or they'll say, there's nothing that really interests me. It's something called anhedonia. And the only thing I can get somebody to say with interests them is their grandchildren, for example. And sometimes not even that. Everything's flat. And that's depression and can be treated. Driving a motor vehicle, very important, okay? Those of us who live in New York City, as a doctor in New York City for years, I didn't even ask about this because I didn't think anybody drove, okay? I was wrong. And it's really important that we talk about driving and if you're still safe to drive. If you're concerned about your hearing, or if somebody else is concerned about your hearing, and hearing is very important for people who are living with dementia. You can't make a memory if you didn't hear and encode what it is you're trying to make a memory of. Okay, that's the same for your vision. And if you're concerned about sex or your sexual function. Okay, again, another question doctors don't ask a lot of the time. So these are kind of the big picture yearly tune-ups, or every other year tune-ups. Next slide, please. There is something called the Medicare Annual Wellness Visit, which I believe is being done more often by primary care providers. Part of the reason is that Medicare pays a little better for it, okay? But the purpose of this is not to give you a physical exam. The purpose of this is to have the provider discover and discuss with you what you might need to do to improve your health now and in the future. So what screens and preventive measures you may need, what risk factors you have for chronic diseases, and what may be interfering with your ability to function at your best in daily life. And it comes in a couple of flavors. During your first 12 months after being enrolled in Medicare, there's something called the Welcome to Medicare visit. But every year after that, even if you didn't get a Welcome to Medicare visit, is the annual the annual wellness visit, okay? Click, please. So some doctors don't do them. But if they don't, ask for a special visit to discuss these concerns and bring in the yearly tune-up form that's you'll get on the slides to go through the things that you need to go through. Next slide, please. Okay, now we're going to talk about shots. And there's always changes in shots, but we're going to go through some of the more common and then some of the ones that have been of concern recently. So the thing you should know about a pneumonia vaccination is that it will not prevent all cases of pneumonia. There are so many different organisms that cause pneumonia, and the vaccine is only for pneumococcal pneumonia, or pneumonia caused by the bacteria called pneumococcus. And there are hundreds of varieties of pneumococcus, and the vaccines only hit 20 to 25 of them. So you can still get pneumonia even though you had the vaccine. But the shots cover the pneumonias, the pneumococcal pneumonias that tend to be most serious and cause the greatest illness in older adults. Okay, so should you get a pneumonia vaccine? Well, it depends on what you've had before and your age, and you're going to need to talk to your primary care provider about that. You've probably, if you watch TV, have seen Prevnar 20, Prevnar 13, all of these new ones coming out, okay? And so there are rules that we follow as to what you should get depending on what you've had. But if you are at higher risk, if you or your loved one live in a nursing home, if you have chronic heart, lung, or liver disease, diabetes, or alcoholism, if you're currently smoking, or if you have more than one chronic condition, you really need to make sure you're up to date on your pneumonia vaccines, okay? Influenza vaccine. Last year, the year before, we had the lowest influenza numbers in years of record keeping. Why? We all wore masks, okay? We didn't spread it. It's coming back now. You need to get it. You don't want to get it too soon. A number of pharmacies are saying in June, July that you should get your your flu vaccine. Don't get it until September, October. The season lasts about 6 months and you want to be protected through that whole season. If you are 65 or older, you want the high dose, okay? As we get older, we don't respond as much to the usual dose of flu vaccine. So there's now a high dose vaccine that Medicare will pay for that you can get, okay? So ask for the high dose. There are 2 or 3 different ones. We don't think about tetanus much. Tetanus is when you step on a nail and you get lockjaw, okay? You don't hear about it very much anymore. It's something, though, that you should get the booster every 10 years because you're not going to be immunized against that rusty nail if you don't. And if you hang around children, you should get the tetanus that contains pertussis or whooping cough because children can spread that to you. All right. Shingles is the recurrence of chickenpox that has sat in your nerve cells throughout your whole life. And then as your immunity wanes, as you get older, it comes out and it can cause this rash, which is very painful. And you probably have heard of or had it yourself, okay? Heard of people who've had it. There was a shingles vaccine that came out about 10 years ago, and it was called Zostavax, and it was 40 to 50% effective. That's now off the market because there's a newer vaccine, Shingrix, that has been out, I think, 3 or 4 years, and it is 90% effective. And you should get it if you are concerned. And I have to tell you, I have had some patients whose lives were changed and not for the better at all because of shingles. Why? Because they got the rash, they had the pain, the rash went away, the pain persisted for years and became really debilitating. There's no reason that should happen. And the vaccine seems to decrease how long you will, if you get shingles, how long you will get have the pain. But like I said, it's 90% effective in preventing shingles. It is 2 shots, 6 months apart. Actually, you can get it 2 to 6 months after your first shot. Some people have a bit of a reaction to the shot, a little flu-like illness for a day or so. But again, it's a risk-benefit situation. The other thing you should know is that if you develop shingles, you can give chickenpox to people who are not vaccinated for chickenpox. So you don't want to be around people who are not vaccinated for chickenpox, okay? Measles, our generation in general got measles by getting measles. You got your immunity. Some of us didn't. And when we went to work at certain places, we had to have the series of measles shots all over again, okay? Or for the first time. Younger people have, for the most part, had measles shots. But if you're around children and children develop measles, you could get the measles. So you should check your immunity with your primary care provider and get the shots if you need them. Next slide. So the 3 that are less commonly discussed, I mean, COVID-19 is obviously very commonly discussed, but it's newer, okay? The new fall booster has come out, and you should have it at least 2 months after your last primary shot or booster, or if you have had COVID, you should be waiting 2 to 3 months. Nobody knows exactly how long. You get immunity from having COVID. That lasts for a while, but then you need the shot, okay? And these guidelines, as you know, are changing constantly, and what vaccines exist are changing constantly. So that we need to keep up with from the CDC or from your primary care doctor. Now, there's been a lot of concern, particularly in New York, about polio. And in general, if you received the series when you were younger, then you probably don't have to worry about it, all right? If you never had shots, and I have some patients who immigrated here, never had polio vaccine, I am giving them the 3 doses now, okay? If you're at increased risk of contact with somebody, or you live somewhere where polio is common, or if you're immunocompromised, there is a suggestion to get 1 additional shot. And monkeypox is something that seems to have peaked, but we'll see if that's true. It's 2 shots 10 weeks apart. At the moment, it really seems that the only people who have been getting monkeypox are those who had close contact or sex with somebody who had the disease, a man who had sex with other men, or with a transgender or gender diverse person who has sex with men during the 2 weeks previously. And recent study just came out suggesting that most of the people who got monkeypox were HIV positive and therefore immunocompromised. So that's where we are right now with immunizations. If you have questions, please put them into the chat, and we can do those. It's up to you whether we do those now or we can wait to the end.
I think we'll be respectful of everyone's lunch hour, and we'll keep them for the end.
Okay, all right. Next slide, please. Okay, preventing cardiovascular disease. Next slide. So this is one of the real miracles of the past 20 years. You see that slide at 1981, 2,500 cases of death from heart disease per 100,000 people, and then move it over all the way to the right to 2014. It's pretty amazing. It used to be, at least when I was growing up, it was not uncommon for 50, 55-year-old men to drop dead, not knowing they had any heart problems. That is really rare now in people who have been getting medical care. There's a lot that has been done, and it's called preventing cardiovascular disease. So what are the things? The first thing is keeping your blood pressure under control, okay? And you should really get your blood pressure checked at least once a year, and ideally at every doctor's visit. And you need to talk with your doctor about what your blood pressure goal is. As I mentioned, there have been studies recently that suggest that you'll live longer and do better if your systolic blood pressure hangs out around 120. Now, for years, we've been saying 150 or 140. Whether you need to go down to 120 depends on if you can tolerate the medications, depends on your life expectancy, depends on a number of other things. So you need to discuss with your doctor, what's your blood pressure goal? Diabetes screening. So there are two tests that we do. It's either a fasting blood sugar or it's something called a hemoglobin A1C that gives us an idea of what your blood sugar's been running over the past 3 months. And the frequency that is suggested is every 3 years if you're between 35 and 70 and you're overweight or obese. Okay. What about if you're over 70? Nope, let's stay on that slide if you would, please. If you're over 70 or if you're diagnosed with prediabetes. So what is prediabetes? Prediabetes means that your hemoglobin A1C is less than what it would be for you to be diagnosed with diabetes, but higher than what is considered normal. It's a little bit of a conundrum because many people, especially older people who are diagnosed with prediabetes, will never live to develop the complications of diabetes. So having them worry about what food they eat or take additional medications makes no sense, okay? So it's really, what is your life expectancy? After you have a diagnosis of diabetes, it's 10, 15, some things it's 20 years before the bad complications of diabetes set in. So it's really, and to treat somebody who's pre-diabetic, to get their hemoglobin A1C back to what we consider acceptable for people who have diabetes doesn't make a lot of sense. So talk to your doctor about whether you should be screened for diabetes, and if you're screened, whether you should be treated, okay? Cholesterol screening. Currently, every 3 to 5 years for those between 40 and 75. And over 75, it's ask your doctor. Why? There have been no randomized controlled trials, high quality studies looking at this in people who are 75 and older. There are 2 studies that hopefully we'll have the results of in a couple of years, and we'll know. So it's really, there are a couple of things that your doctor can do to figure out what your risk is and whether you should be treated for high cholesterol. And aspirin, we were giving to everybody 55 and older, basically, to prevent cardiovascular disease for years and years and years, that baby aspirin. A couple of years ago, the actual study that we needed was done, and we found that adults who were 60 and over, who were given the aspirin, randomized to take an aspirin, did worse than the people who didn't get an aspirin, okay? They had no benefit from a cardiovascular point of view, and they were more likely to bleed, have a serious bleed. Now, there are lots of possible reasons for that, and probably the biggest one is that slide I showed you before this, with all the things we've done that have decreased the risk of cardiovascular disease. So if you're doing all of that, the aspirin doesn't add a whole lot. In fact, it probably adds nothing, which is why we now recommend that you not take aspirin unless you've already had a heart attack or other cardiovascular problem. So speak with your doctor about it. Okay, next slide, please. We're moving to screening, next slide. And we're going to talk a little bit about screening and what you really need to know. So the first thing, it's not just a blood test or an x-ray. A lot of people say, oh, I just get, it's a blood test, I get a PSA. It often involves more than the initial testing. So before you get screened or you have your loved one screened, make sure you know what the next diagnostic and therapeutic steps would be. Because if the test is abnormal, you may have to do more x-rays, you may need to have a biopsy, you may be recommended to take a medication, chemotherapy, surgery, radiation. Next, click. If you know that you would not follow through with these, don't get screened. I have patients who say to me, if they found something on that mammogram, I don't care. I would not have my breast removed, not even a piece of my breast removed. I'm not going to have surgery. Then we don't screen you. Okay. Next slide, please. So what diseases do we screen for? If you can just show what's on this. So the first thing is they've got to be common or it's not worth screening. Okay. There has to be a serious consequence of the disease. There has to be something you can do about it. And the screening test itself has to be accurate. And that's the problem with prostate. The PSA is not an accurate test. And in fact, the man who developed the assay has had 2 op-eds in the Times saying, sorry, okay. It's just not good enough to tell us the difference between people who will suffer from prostate cancer and those who will just live with it and nothing will happen. And in autopsies of men who are 80 and older, 80% of them have some prostate cancer in their prostates, but never needed any treatment for it. It never caused any problems for them. So we're looking for diseases where early treatment results in better outcomes than if you waited until you develop signs or symptoms to be treated. Because otherwise you'd be at risk of suffering the harms of treatment years before you would benefit from it. And again, I keep using prostate cancer as my example because there are a lot of men who are impotent, who have urinary incontinence, who have terrible diarrhea that they can't deal with because of the treatments they received for that elevated PSA and the fact that they had prostate cancer and they wanted to make sure that it never spread. Okay. And whether that actually worked for them or not is up in the air. So now we're learning to do things like test, do watchful waiting, keep people under observation more, and not just jump to treatment if we don't know what the course of the disease will be. But it's really hard to know you have cancer, whatever it is, and live with it. People want it out. So that's why it's important to decide whether you would do anything, or and if you wouldn't, then don't drive yourself crazy by knowing the answer. Next slide, please. So these are the things that we screen for cancer, and the first is breast cancer, and we do mammography. And the suggestion is every 2 years, not 1 year, it's every 2 years if you're less than 75. And if you're older, discuss with doctors because the studies only went to age 74. They are now doing some studies and doing some modeling to try and give us better ideas of what to do for people who are over 75. But the feeling is if your life expectancy is less than 10 years, you're unlikely to live long enough to have a cancer detected by mammography cause you suffering or death. The kinds that would are so aggressive that our treatments don't work for them anyway. So that's the yin and yang of it. Cervical cancer, it's very interesting. It's a pap smear every 3 years or HPV testing every 5 years. But if you have done that regularly, then you can stop at 65, okay? And most people who die of cervical cancer are over 65, but they weren't screened, okay? Prostate, we've talked about, and that basically we're saying if life expectancy is less than 10 years. Colon cancer, there are 2 ways to screen. There's with the stool test, and if you're going to do that, you have to do it yearly. And that assumes you never had a previous little growth. And here, for all of the colon cancer screening, we stop at 86, or if you have less than a 10-year life expectancy. And between 75 and 85, it's an individualized decision. And, some people just are don't think their chances are enough or would not have the surgery, whatever. I've never had a patient who's told me, actually I had one, who was upset that they were done getting their colonoscopies. I had somebody who was 90 and probably will live to 120, and she really didn't want to die from colon cancer, so she's getting another colonoscopy. So colonoscopies every 10 years, CT colonography, which is a new thing, every 5 years. The problem with CT colonography is that it is an X-ray. You have to do the same prep, okay? And if they find a polyp, then you have to have the polyp removed. And most of the time at this point, that cannot be done when you have the CT colonography done. So you have to do another prep and have it taken out. Lung cancer screening is the low-dose CT, and it's done yearly in people who are between the ages of 50 and 80. If you have a 20-pack year smoking history. So what does that mean? If you smoked 1 pack a day for 20 years, or if you smoked half a pack a day for 40 years, okay? Or a quarter for, I've lost my, I don't know, would it be 80 years? Yeah, for 80 years. That's a 20-pack year smoking history. Or if, who are still smoking, okay? Or if you've quit within the last 15 years. But you stop at age 80. If it's been over 15 years since you smoked, you stop getting screened. Or if you have a condition that greatly decreases your life expectancy, okay? But I have to say, between this and some of the new immunotherapy, we are seeing better results from people who have lung cancer than we saw previously. Next slide, I'm coming toward the end. There are other disorders that you should talk to your doctor about getting screened. Osteoporosis, very important for women because when you go through menopause, your estrogen decreases, and then as you get older, your estrogen decreases, makes you at higher risk for fractures. And as I mentioned before, there are medications that can help. For men, it's controversial. It depends on your risk. You should talk with your doctor about it. An abdominal aortic aneurysm is something that is in the aorta in your belly, and it balloons out and it can rupture. It's actually what Lucille Ball died from. So anyone who ever smoked or has a family history of an abdominal aortic aneurysm should get screened, and Medicare will pay for that once between the ages of 65 and 75. HIV, if you are at high risk, if you have multiple sexual partners and new partners, a lot of older people think they don't have to worry about this. Wrong. Being old does not protect you from HIV or other sexually transmitted diseases. You need to think about it, and if you're back on the dating market again, it's an important thing to consider. Hepatitis C is now a hepatitis that we have treatment for, and I'm sure if you watch TV, you're aware of it. It's all over the place. You should be screened at least once between ages 18 and 79. And if you had a blood transfusion before 1992, which is when we were able to start screening for hepatitis C, you should get screened. And if you ever were an IV drug user, you should get screened. Next slide. So that's a lot of information. You need to look at it specifically for yourself, for your loved one. Can you hit the little click? And remember, this is you throughout your entire life. You're the same person, okay? You may look different, but you're the same person. And you can make your decisions as to what really matters to you. Is it quality of life? Is it length of life? Those sorts of questions. Next slide, please. And just a plug for the book. And this is a 30% pre-publication discount if you want it, and it will be coming along to you. Slides off, and let's have some questions.
Yes, thank you, Dr. Leipzig. That's a lot of information to take in, but it was all very important and very wonderful. We do have a couple of questions. These are around the area of information of family of people with MCI or Alzheimer's disease. They want to know what are the best preventive strategies for the adult children, grandchildren of people who have MCI or Alzheimer's disease.
You know, it's a great question. The first thing is exercise, exercise, exercise. All right. It's the only thing we've seen that seems to make a difference. Don't get head injuries, don't play football. I think I'm not being facetious. There are 7 things that have been shown to be preventive. And of course, off the top of my head, I'm not going to be able to tell you all 7, but most of them have to do with cardiovascular health, because we have so much dementia in this country that is due to vascular disease. And so keeping your blood pressure controlled, making sure your lipids, your cholesterol is where it should be, doing exercise, use it or lose it with your brain, okay? Keep trying to people who are more highly educated are less likely to develop clinical dementia. So those are all things. On another side, there are all sorts of studies going on now. And if you want to be involved in a study to either try and decrease your likelihood or to know whether you are at risk, and that's a big question. You really have to decide if you want to do that or not. Some people, it's very helpful and they feel it forces them to do everything they possibly can to avoid it. Other people get very depressed and it's a hard thing to live with. But there are clinical trials. The Alzheimer's Foundation can certainly point you toward those. There's a website called clinicaltrials.gov that has a lot of information about clinical trials. So you can see if you want to get involved in things like that.
And just a slight extension of that question, should the adult children of parents who may have MCI or early stage Alzheimer's disease be monitoring? And when should we flag potential concern for those conditions? And a follow-up, what are the best next steps when the parent does not live with you?
So let me make sure I've got this right, okay? It's the adult children who are
Yes.
looking at the parents who
Yes.
have mild
Who may have mild MCI or
and
early stage Alzheimer's disease. What should they be looking for or monitoring if they suspect that? And at what point do they need to flag a concern to their parents' providers?
okay. So the first thing to realize is that everybody screws up at some point. So you don't know where your wallet is, you miss an appointment. These things happen. And just because they happen doesn't mean that you have dementia. So give people a break. On the other hand, there are some things that if they start happening a lot, you need to be concerned. And with many forms of dementia, the first things that happen are in what are called executive functions, tend to be structured in the front part of the brain, ability to stay organized, complete tasks, problem solve, pay attention. Those are things that as you get older, there is a slight decline, but if it becomes a problem, and for me, if somebody stops being able to take care of their medications on their own, if they stop being able to take care of their finances on their own, if there are concerns about their driving, those are things that say to me, think that this has progressed. So that would be my point.
Okay.
You know, a lot of times people wait until somebody's repeating themselves, or getting lost, or the keys are never found, you know, that sort of thing. It's a little further on. So
Okay.
I would go earlier.
Okay, and that leads me to my next question, which is, this person believes that her mother has dementia of some kind. Her personal care habits have changed dramatically, and she has little to no interest in activities now. But she rallies at medical appointments and the doctor tells her she is doing great. What's the best way to communicate with my mother's physician without doing it in front of her and becoming the bad guy?
I think it's a great question, okay? And people are nuts right now in terms of HIPAA and all that as to who will talk to who. If you are your mother's healthcare proxy, or if your mother gives permission for you to talk to your doctor, that's the easiest way to do it, all right? With my patients, I have family members who call. I don't have permission. I will listen, but I don't give any medical information out. But I do incorporate it into my next visit with them. So that's another way to deal with it.
I think that's all people are, they're just trying to get the information to the physician, but not in front of their loved one.
Right.
Yes,
Right.
that's okay.
And I mean, sometimes they catch me during, when I walk out of the room at an appointment. Well, okay, that if you can't do it any other way, because that kind of screws up my schedule. But other than that,
you get tackled. Okay. Now here's an interesting question. My mother has reoccurring urinary tract infections, UTIs. They send her over the moon. The memory care residence doesn't notice them and notify the doctor until my mother has become much weaker. Would you advocate for a maintenance dose of a UTI medication to keep the infections away?
two things on that. I would advocate that the memory center's staff get trained to know when somebody's not doing as well as they were doing. Okay, because these things have,
barring that.
I mean, they really have early warning signs. Let's put it that way. If you can't do that, there are medications that you can give in low dose. Nothing is without side effects, but you're usually okay with these medications. Also, cranberry juice, some people are using to try and prevent. So I would start with just getting cranberry juice on her diet.
Okay. And here's one that we get on the helpline a lot. I live in a rural area. There are no neurologists available for diagnosis or treatment. Is it possible and or beneficial for my parents' primary care physician to refer my father to a neurologist for a telemedicine visit in a larger city? This would be regarding dementia.
I think that's possible. Okay, I'm saying I would suggest that they be referred to something like one of the national Alzheimer's disease and related diseases groups, because a solo neurologist, it might be hard to do that. I would think the others are more set up for it. But yes, I mean, it certainly could be done. The thing to know is that there are all sorts of regulations around video visits these days. So just to make sure, but with a video visit, they would at least be able to see the person, do some testing. You can't do the best testing in that way, and get the history to at least get things started.
Okay. All right. So a clinical or hospital practice based in dementia care
Yes.
would be the place to try and get connected to, rather than a singular practice.
I think so. I think you'll get more of what you need.
That's great information. Okay, we have come to the end of our time, sadly, today. We want to thank Dr. Leipzig for this instructive and important webinar. We will remember screening, detection, intervention. I appreciate so much your time and helpful information about how to best protect our people with dementia, as well as ourselves. I also want to thank everyone who attended this Care Connection today. Please feel free to contact us at education@alzfdn.org or give us a call 12 hours a day, 7 days a week, I will include the hotline number in the email, and I will be sending an email with all of the handouts and information, so not to worry. And thank you for your thoughtful questions today. Before we end, I want to encourage you all to sign up for our next Care Connection webinar on Thursday, November 10th at 1 p.m. We will have a return visit from Danuta Lipinska, who's a specialist in aging and dementia care. She will be speaking on person-centered and creative solutions for successful caregiving for people with dementia, as well as coping strategies. This promises to be a supportive webinar for professional as well as personal caregivers. Take care, everyone. Till then, again, Dr. Leipzig, thank you so much. We're getting lovely comments for you in the comments box that it was a great experience. Thank you so very much for your time.
Thank you. Bye-bye now.
Bye, everybody.